ventricle.
Okay, we're not going to do too many details on that yet because that's a different chapter. But if you need to visualize it, it's kind of like that. Comes here, goes out to the lungs, gets oxygenated, comes back.
What is that?
The pulmonary veins.
Thank you.
Okay?
And then it goes to the system. So the both.
With the S1 and S2 of those, the S1 is pulmonary cerebellar valve closing. No.
The S1 is AV valves closing.
AV. Okay.
S2 is the SL valves closing.
But that's not the S2 is not a combination of two.
Yes, it is.
It is.
Yeah, the aortic and the pulmonic.
S2 is the.
Okay, let me add another piece of information here. Both sides of the heart are doing their thing at the same time. Okay? So, the blood here in the right atrium is being squished out of the right atrium into the right ventricle at the same time that the blood that's in the left atrium is being squeezed into the left ventricle. Okay? And then both ventricles contract at the same time. So both AV valves close at the same time. And then both ventricles begin to relax at the same time. So both SL valves close at the same time. So your S1 is when the AV valves close. Your S2 is when the SL valves close. Because on both sides of the heart, things are happening at the same time. Okay? Everybody understand that? Okay, and that's kind of important. I've had an argument with one of my lab partners in med school over this because I'd already been in nursing school and I knew this. And he was trying to say that this all happened, in a line. And I'm like, no, it doesn't. Okay? All right.
You hear four sounds.
Okay. Right, you have fours in two.
There's videos you can find on like YouTube. You can watch it like
Yeah,
animations
you can
of the
watch-
heart pumping.
You can watch animations on YouTube and it'll show you the blood running in and running out, little valves closing, the whole 9 yards. Okay? And if you are a very visual person, it's worth your time.
Yeah.
And it's kind of fun. Okay, now another thing to notice here though. How far is the right ventricle having to pump the blood?
The right ventricle.
The right ventricle. Yeah, from here out to here. Okay? How far is the left ventricle having to pump blood?
Much farther.
All over the place. So what can you tell me about the pressure on both sides?
The pressure is higher.
Left is going to be higher.
The
than
pressure on the left side is going to have to be much higher.
Is that why the
Left side of the heart is going to have to pump it much harder to get it to go where it needs to go.
Is that systole over diastole?
That's why the left ventricle is thicker than the right ventricle. Now, sometimes you'll have athletes that drop dead out on the field. Ever heard of that? Okay. And sometimes they will throw around words like left ventricular hypertrophy. Hypertrophy means overgrown. Okay. Now, all athletes are going to have hypertrophy of their muscles, including their cardiac muscle. But think about what happens if this muscle hypertrophies too much.
There's no room for blood.
There's no room for blood. Okay? So, left ventricle hypertrophy that's abnormal, that's not just a consequence of working out, okay, is eventually going to kill you, and it's especially going to kill you when you're trying to move a whole lot of blood through there. The heart just can't do it. Yeah, and you can pass out and have cardiac arrhythmias, and it gets real complicated from there. All right, so everybody with me so far?
Yes.
Would a sign of that be high blood pressure?
Yes, it would
Yeah.
tend to be high blood pressure. Sometimes Sonny, that's a technical question. Sometimes you have left ventricular hypertrophy with heart failure, and that's a whole different ballgame. All right, now Kitty asked a question here: systole versus diastole. Okay. Systole is what is happening when the ventricles are contracting. Systole is what is happening when the ventricles are contracting. And when you've got a blood pressure cuff on somebody's arm, which side of the heart are you listening to? The left side. Okay. Is there any way that you can measure right ventricular systole? The answer is yes, you can, but you have to use a Swan-Ganz catheter, and your patient's usually in the intensive care unit.
Oh, that was a trick question.
Yes, it was a trick question. Okay. All right. So systolic pressure. Usually, what we're worried about is the left heart. Okay. Systolic pressure is what is happening when the ventricles are pumping. Okay. The pressure is high enough that the back doors have blown open, and blood is flooding into the arterial system because it's being pushed by the left ventricle. Okay? Then what's diastole?
When it's at rest.
The ventricles relax and they are now starting to fill. Okay? The pressure in the ventricles goes down very, very low because they are no longer contracting. Does the pressure in your arteries go to zero?
No.
Why not?
Blood still remains inside of the chambers.
Because your arteries stretch when you shove blood into them, and then they come back and relax gradually. So, systole is the pressure when the ventricles are contracting. Diastole is the pressure in the system when the ventricles are relaxing. Okay. From that, you get your systolic blood pressure and your diastolic blood pressure. All right, let's back up a minute now that we got the big picture and start looking at some of the details here.
Okay, we're looking at the anterior view.
I said, I feel like I'm cool with this because I cut up hearts because I feed my cat hearts. And then I had to do the whole, my cat eats heart for breakfast. It's a really good source of taurine, so there you go. There we go.
Or you have to do
Yeah, heart.
specifically the heart.
Yeah.
All right. Now, on the outside of the heart, okay, these next two pieces of information are a little bit hard to grasp if you are looking at a plastic heart, because the plastic heart is plastic. It's hard. There is a groove or a sulcus between the atria up here and the ventricles down here. If you want to tag along with Margot and cut up hearts for her cat, you can probably see it because there'll be a little bit of a separation there between the two. Okay. There also is a little bit of a groove between the left ventricle and the right ventricle. Okay. So you've got the atrioventricular or coronary sulcus, and then you have the interventricular groove. Now, the right side of the heart remember your heart's pointed down this way. Your right side of the heart is on the right side, but it's also more, it's twisted so that it's more posterior. It's more central and it's more posterior. Okay. The left ventricle tends to be anterior and more superior. Okay. All right. So why do you care? The reason why you care is because of the blood vessels that are in there.
Because of the what?
Because of the blood vessels that are running in those grooves.
So about that, you said that the right is posterior and
The right ventricle is sort of posterior and inferior. The left ventricle is sort of superior and anterior. So if somebody said that an individual had a posterior heart attack, they had a heart attack where?
in the right ventricle.
In the right ventricle. All right. So that's those two things.
Got it.
Okay, another piece of detail. If you look inside of these plastic hearts, you don't see a whole lot of detail on the walls. The walls of the atria are smoother than the walls of the ventricles. However, they do have little muscles in them called pectinate muscles, and you can't always see them. The atria also have little projections on them called auricles.
Oh yeah.
So the atria can also expand a little bit. It's like having a purse that is usually one size, and then it can, like you have a gusset on it, and you can pop it up a little bit. That's what the atria is sort of like. It allows for there to be a little bit more room in the atria. The problem with that is that if the atria don't beat, it gives a place for blood to pool and clot.
Mm.
Okay? Yes, Kelly?
I'm just gonna ask, so you mean like a suitcase that you can unzip and
Yeah.
expand it further?
Mhm.
Okay, I have no idea what you're talking about.
Yeah. Except for it's never zipped.
Okay.
It's like that
Like an accordion.
yeah. The thing exactly, thank you. A gusset is something that will go like this and then it will expand when you need it. I mean, like an accordion or like a suitcase zipper kind of thing.
That's a good analogy for
Yes.
this picture.
All right, now between the two atria, in fetal life, you have a connection called the foramen ovale. But in adults, you no longer have that connection. You just have a little flat space called the fossa ovale, or some books, the fossa ovalis. And you're going to have to look on each piece of plastic to see what, if anything, they are using to depict the fossa ovalis. Now, we already talked about the leaves of the AV valves, and we talked about the chordae tendineae and the papillary muscles that they are attached to. The innards, the inside of the ventricles, is lined by endocardium, but the wall itself is kind of thrown up into bumps and grooves. Okay? And those bumps and grooves are called trabeculae carni. And don't ask me why. I don't know why. I think if I'd have done it, I'd have made a smooth wall, but it's not smooth in there.
I'm sorry, what did you just make mention of?
Trabeculae carni.
Okay.
Okay, now let's talk about the blood circulation.
Foramen valley, that's what I was trying.
What's it called in babies? The duck?
Foramen.
It's the-
In babies, yeah, it becomes a fossa.
All right, now, if you have an individual with a very thin chest wall, for example, if you have a little kid at home, this can be a lot of fun to do. You can hear each of the individual valves close at a different place in the chest. And these places where you hear the sound is based on where the sound waves travel, not based on where the valve is located. Okay? So you hear the sounds of the pulmonary valve best right over here on the left between the second and third ribs. You hear the aortic valve on the other side. Is the aortic valve part of the right heart? No. Is the pulmonary valve part of the left heart? No. But they're pointing that direction. So that's where the sound waves go. Okay. The tricuspid valve, okay, down towards the fifth intercostal space. Okay. And then the mitral valve is pointing almost straight at the point of maximum impact. So the place to hear the mitral valve most clearly is at the point of maximum impact. Now, for the most part, when you stick a stethoscope on somebody's chest, you hear lub dub. Okay? You're hearing both AV valves together, you're hearing both SL valves together, and you're not distinguishing between the two. But if you want to distinguish between the two, here's where you would listen. And if you have a kid or somebody with a real thin chest wall, and you take your stethoscope and you start one place, and you move your stethoscope just a ½ inch at a time, all the way around the sternum, you will hear the sound of the valves change. Okay? You'll hear lub dub, but the lub dub sound will change, and you'll be able to tell, okay, I'm hearing a different valve here because the pitch changes a little bit. Okay? This is one of the things that is becoming a lost art, even in medicine. Okay? People are becoming way too dependent on ultrasounds and machines and all those other things. Old-time cardiologists could tell what was the matter with you from listening to your heart and from feeling your pulse. Okay? We had a professor in medical school who was an old-time cardiologist, and he could tell you your pulse pressure, which is the difference between your systolic and diastolic pressure, just from feeling your heart, or just from feeling your radial pulse,
Wow.
which is like voodoo. But he could do it. Many Chinese medical doctors could do that. Okay. Now, coronary circulation. Let's look at this first on this, and then we'll look at the heart itself. In any circulation, you have arteries, capillaries, and then veins. Okay. Here is the same deal. In the coronary circulation, you have the same deal. You have arteries, they go out to capillaries, and then the blood's picked up by your veins. The heart doesn't get its blood from the blood that's sloshing around in the chambers. However, it does the work and it gets the first dibs on the oxygenated blood. Just past the aortic valve, almost right in the cusps of the aortic valve, you have the coronary arteries take off. And there's a left coronary artery and a right coronary artery. And yes, the left coronary artery in general supplies the left side of the heart. The right coronary artery in general supplies the right side of the heart. Okay. Both arteries split. The left coronary artery splits fairly quickly into a branch that bends back around behind the heart. So if you're looking at the heart like this, comes out and goes back around the heart. Okay. That's called the circumflex artery. The other branch from that split runs right down the groove in the front of the heart here. And we said that groove was the interventricular groove. So in the new books, that's called the anterior interventricular artery. And if you talk to an anatomist, that's what they're going to call it, the anterior interventricular artery. Makes sense, right?
Mm-hmm.
Okay. That's not what cardiologists call it. Okay. Cardiologists call it the old name, which was left anterior descending. Now that kind of makes sense because the other branch, does it descend? No, it turns around and goes towards the back. The left anterior descending, or the LAD. The left anterior descending, or the LAD, is the major blood supply to the left ventricle. So some books will tell you that this artery is called the widowmaker. Okay. And if that one gets blocked, you're in a heap of trouble.
Widowmaker?
Mm-hmm.
Widowmaker. The left anterior descending, or the LAD. Okay. Your right coronary artery does not branch right away. It comes down the right ventricle, and then it splits into a posterior interventricular artery and a marginal artery. Now, a posterior intervention. Wait.
Yeah.
No, it just splits into a marginal artery. Excuse me. The right coronary artery comes down and it splits into, it gives off a branch as the marginal artery, and then it continues around the back as well. Okay, so you've got circumflex, you've got LAD, you've got right coronary, and you've got marginal. Okay?
Right coronary is posterior, though, right?
It comes down the front and then it goes posterior. Okay, so your circumflex goes posterior this way. Your right coronary comes down and then goes posterior this way. Now, the pictures of the heart will drive you crazy. The plastic models of the heart will drive you crazy. The dissections that you do of a heart will drive you crazy because these arteries and veins are sometimes look slightly different. This is why they do cardiac catheterization. Nobody told these arteries that they had to be arranged exactly this way. And so you'll look at the models and you go, wait a minute, I think that that's what this is based on where it is, but it looks a little different than it does in the book. Okay? That's because it might be a little different depending on the individual. Okay? Now, the heart is also, the thing that also makes these things look a little different is that the heart is very good at collateral circulation. Collateral circulation means that your vessels anastomose or come together so that blood can get to a body part more than one way. Okay? Now, we do this all the time, right? Especially if you live in a city. If there's a traffic jam, what do? You go around it. You go on a side street and go around it. Okay? An anastomosis is an arrangement of blood vessels that allows you to take a side street. Okay? Okay, you can get to your destination more than one way. Right, now, the veins, you got a similar deal with the veins, only these are usually even more difficult to look at on a model. In general, you have 3 veins. Mama vein, papa vein, and baby vein. You have a great cardiac vein, a middle cardiac vein, and a small cardiac vein. And they all run into the coronary sinus. And the coronary sinus is usually the easiest one to see because it's right on the back of the heart in the groove here between the atria and the ventricles. Okay, the coronary sinus. The coronary sinus is deoxygenated venous blood, and it just drips right into the right atrium. So the blood in the right atrium is coming from the superior vena cava, the inferior vena cava, and the coronary sinus. Superior vena cava, inferior vena cava, and the coronary sinus. So looking at okay, so on this picture, here you have your LAD, or your anterior interventricular artery. You have your great cardiac vein. You have your circumflex going around. Here you have your right coronary artery going around, and it's going to continue on the back, and it's giving off your marginal arterial branch. Over here you have your small cardiac vein. Flip the heart over. Your great cardiac vein is coming in here. Your small cardiac vein is coming in here. Wait, here. Okay. Here's your middle cardiac vein. What's that? I don't know. Okay, you see what I mean? Yeah, they just thought it would look pretty, so they added another vein. Enough to make you crazy when you're trying to learn this stuff. Okay. Okay, if you cut the heart open there, you can see how the left ventricle is a whole lot different than the right ventricle. The left ventricle is more anterior and more superior. The right ventricle is more inferior and it's more behind. Okay? The right ventricle has a much thinner wall than the left ventricle. Remember I said that there was a fibrous skeleton to the heart, and that the veins were sticking in the fibrous skeleton? Here's your fibrous skeleton. Okay. And here are your veins. Okay. So when they have to replace a valve, are they having to chop through myocardium? No. When they are having to replace a heart valve, are they having to chop through myocardium?
Valves are not, they're not muscle.
They're not muscle, okay? And they're not attached to muscle. They're attached to this fibrous ring here, okay? So you may need to get things out of the way, get your atria out of the way here, but your valve is in that ring, so they can cut that away and then sew their valve into that.
But it's not surrounded by the.
It's surrounded.
Right, so in
This
this
is looking-
picture, it's not cut, only the valves are cut, the myocardium isn't cut.
Correct. Okay. What in this picture? They've taken the atria off,
Oh, I'm there now.
and
I
see you're looking at it that way. They've taken the atria off. They've taken all these great blood vessels here off. Okay, where my hand is. Okay, so you're looking at it this way.
In the ventricles.
You're looking what is between the atria and the ventricles.
Mm-hmm.
Okay, so that's what your valves look like and are arranged like.
I see.
They're
Okay.
connected to this fibrous skeleton. The fibrous skeleton isolates the ventricles from the atria, gives something for both the muscles to pull on and the valves to be sitting in or attached to. And that's why you don't necessarily, and I think sometimes depending on what approach, they may actually go through myocardium, but you don't have to cut the heart in half to get to a valve. Does that make sense?
Mm-hmm.
Is that like tendons?
Yeah.
The skeleton?
Fibrous, no, it's fibrous connective tissue.
Do they have that surgery? Like, can you watch it online somewhere? You think? Have you ever been able to find it? Of
there
them
are-
actually cutting
yes.
through, so we can visually see it.
There are places where you can see that online. I used to have a website, and I'm not sure I can even find it anymore, where it's actually, I think it was a subscription website, where you could go in and watch different types of surgery. But if you look, and in both nursing school and med school, we had a chance to go in and observe. Cardiac surgery, those takes hours. They usually have you standing way off over here, so it's hard to see. But okay, questions up to this point?
I kind of feel like I missed something. The atrium is not as thick as the rest of the heart as far as the myocardium,
Correct.
and it is still the same tissue though?
Yes,
Because it's a
you
totally
do.
different color and coating.
Right. You have cardiac muscle in the atrial walls because the atria contract.
Yeah.
But it's much, much thinner than the ventricular walls because it doesn't, it just has to push the blood a little ways. It just has to kind of top off the ventricles. It's not even pushing blood as far as the lungs.
So the articles are made up of the same tissue, it's just wrinkled, so that's why it looks
Yes.
different.
Yes. All right. Now, several things that you can do. You can look at the models if you can get them away from the people who are supposed to be learning them so they can teach us.
Supposed to be mild.
You can look at the blood pictures upstairs. I will be straightening up the posters up there, as we have some posters of the heart up there. Okay, we have several books up there that have pictures of the heart. You can work on your Marib study guide. Okay, so I'm going to turn you loose now, but I don't want you just running around partying. You're supposed to be studying. You're supposed to be doing labby kind of things here. Okay?
So the exam is Wednesday?
Tuesday.
Tuesday, but it does not include.
It does not include what we covered today. Okay? It's special senses, endocrine, and blood.
Okay, that's what we
Yeah.
got, but.
And remember, I told you this before, I do not have as many models for special senses, endocrine, and blood. So you're going to see pictures and you're going to be asked a lot of questions, a lot of explain to me this kind of questions on the lab exam. There's also going to be the brain on the lab exam.
For the cranial.
Cranial nerves and the pituitary gland, the pineal gland, the hypothalamus, all that stuff. Okay. All right. So everybody have a plan how you're going to use wisely the next 45 minutes? Come and get me if you get stuck out there.